Good evening, Bhuvan. Good evening, Shamim. So finally, we are all set for today's session, and today I have selected few questions from pathology. Some questions are comparatively easy, some are little difficult, and some are like out of the syllabus, you can say. So I am very sure this session is going to be very interesting one. Right. So starting with the very first question, here a 24-year-old male develops generalized edema, which happened 2 weeks after upper respiratory tract infection. Urine analysis shows proteinuria 4 plus. Light microscopy is normal, whereas electron microscopy shows diffuse effacement of podocyte foot processes. I think very good, Bhuvan. Okay, so yes, the moment you have these much amount of keywords, the clinical diagnosis is very easy, very good, right? So there is generalized edema, clear? This is also known as anasarca. Okay, then there is massive proteinuria 4 plus, right? So this is massive proteinuria. Then there is light microscopy is normal, and electron microscopy showing diffuse effacement of podocyte foot processes. Okay, so this is very classical for minimal change disease, right? So this is very classical for minimal change disease, right? MCD, obviously. You are absolutely right, Dr. Bhuvana Raghu, right? So this is MCD. Now here, one of the important correlation is like, since the light microscopy was normal, so this condition was known as minimal chain disease. But it's only later on when electron microscopy was done, then it was realized that it is not minimal chain disease or normalcy on light microscopy. It's actually effacement of the foot processes of podocytes, right? So that was, this nomenclature was a kind of misnomer. Now here the question is something about like which cytokine released by T cell is believed to play a central role in this disease. And yes, Bhuvana, you are absolutely right, this is IL-13, right? So this is IL-13 which plays a role in all these pathological changes of minimal change disease, which is also known as nil deposit disease, right? So it is also known as nil deposit disease. So again, minimal chain disease is very hot favorite for exam setters. In one or other way, they are definitely going to include a question from this topic. Okay, so please don't do any sort of mistake, try to read it as much as possible. So yes, this question was slightly out of the box. Moving forward to one good question, and I think most of you can answer it very easily, right? So here a 38-year-old woman, she is presenting with recurrent oral ulcers, joint pains, that is arthralgia, and a photosensitive rash, especially it means on the exposed areas of the skin. Now lab test shows positive anti-nuclear antibodies and anti-double-stranded DNA antibodies. Then renal biopsy shows diffuse proliferative glomerulonephritis. Now I think most of you must have understood what is the clinical diagnosis here, so it becomes very easy to answer which type of hypersensitivity reaction is this. So if we go with the keywords, a lady with arthralgia, right, then photosensitive rash, what you call malar rash or butterfly rash, then anti double stranded DNA is very important here, and also anti nuclear antibodies. Now this is one of the most sensitive antibodies, and anti double stranded is also, you can say, specific, correlates with the disease activity, and this is classically case of SLE, and this is lupus nephritis. Clear? So this is a classical case of SLE, and I think everyone can answer this. SLE type 3, very good. This is immune complex deposition. Clear? So this is how you should approach this question. Now moving forward to another question, diabetic woman has fever and painful micturition, that is dysuria, and then urine culture shows growth of Escherichia coli, right. So it is sensitive of urinary tract infection. Now histopathological examination of the kidney shows numerous neutrophils which are infiltrating the tubules and interstitium, and there is formation of white blood cell cast. Now what can be the diagnosis here? Bhuvana, yes, very good. Super, yes. Now here, known case of diabetes mellitus, right. So the patient is a known case of diabetes mellitus, developing dysuria, painful micturition, then there is numerous neutrophils which are infiltrating the tubules and interstitium, but most importantly there is one more clue, and that is WBC cast, right. So the moment you have this particular word WBC cast, straight away you can go for acute pyelonephritis, right. So WBC cast, go for acute pyelonephritis. Oh sure, in systemic systems will be also there, yes. Okay, so this is how WBC cast will look like. Moving forward to next question. Elderly male presents with back pain and anemia. Peripheral smear is showing Rouleau formation, then electrophoresis showing M spike, and then the bone marrow biopsy is showing sheets of plasma cells. Now the moment you have these much of keywords, I think all of you can understand what condition is this. Yes, this is multiple myeloma, very good. So elderly male, right, then presenting with back pain, anemia, there is Rouleau formation, then M spike, yes, on electrophoresis, and then plasma cell. So obviously this is a plasma cell dyscrasia. So this is classical for multiple myeloma, right. So the clinical diagnosis is multiple myeloma, and yes, it is IL-6. Okay, yes, on X-ray it will be showing you punched out lytic lesion. So X-ray, especially skull, it will show you punched out lytic lesions. Very characteristic word. Wonderful, wonderful. Right. So this is multiple myeloma, IL-6. Then moving forward to next question, a 45-year-old man with long-standing rheumatoid arthritis, right? So long-standing rheumatoid arthritis now is having pedal edema, means edema over the foot, and frothy urine. Urine analysis shows nephrotic range proteinuria, and then the biopsy when stained with Congo red shows apple green birefringence under polarized light. Now I think the moment you have this much of description in the question statement, definitely you can make out the diagnosis. So here the patient is a known case of long standing rheumatoid arthritis. Now he is having affection of some kidney leading to pedal edema and frothy urine. But the important thing is like Congo red staining under polarized light, right? So under polarized light shows apple green birefringence. Yes, I think everyone can answer this. This is a classical description for amyloidosis. Clear? So this is a classical description for amyloidosis. Now we have to identify what type of protein you will see in this case. Now remember here, this is a long standing case of rheumatoid arthritis. So it means it is a chronic infection, or you can say chronic inflammation, condition with chronic inflammation. So in such cases the answer has to be serum amyloid A. So if you know the type, it is AA. Clear? So this is chronic inflammatory condition, chronic infection. It will always give rise to secondary amyloidosis. So this is a case of secondary amyloidosis, and in secondary amyloidosis remember AA. Okay. So apart from rheumatoid arthritis, sometimes there can be mention of chronic osteomyelitis or bronchiectasis. So all chronic infective or inflammatory conditions. So that's secondary amyloidosis. Yes, multiple myeloma is primary. Very good. Now moving forward to next question, a 16-year-old boy, right? 16-year-old boy has spontaneous hemarthrosis after a trivial trauma. PT is normal and activated partial thromboplastin time is prolonged. Factor VIII deficiency is markedly reduced. Which coagulation pathway is primarily affected? This kind of question we have discussed yesterday in physiology also. So just a twisted version of that, you can say like something like that. So right here, so there is a 16-year-old boy, clear, spontaneous hemarthrosis, right? So heme is blood and it is accumulating within the joint. So hemarthrosis, PT is normal, but activated partial thromboplastin time is high and factor VIII levels are reduced. So yes, this is a classical case of hemophilia A, right? So this is classical case of hemophilia A, and factor VIII is a part of intrinsic pathway of coagulation, right? So Kumar Yo-Yo, yes, you are absolutely right. Bhuvana, yes, you are right. So this is intrinsic pathway. Okay, so that's how you should remember. Anyway, moving forward, a 52-year-old woman presents with a breast lump. Histology reveals malignant cells which are arranged in a single file or Indian file pattern. Then E-cadherin immunostaining is absent. Now, what is the diagnosis? Now, this is one very favorite question and it has been repeated many number of times. So, here the classical keyword is single file, also known as Indian file pattern, and one more clue is E-cadherin is absent. So, these 2 points they hints towards invasive lobular carcinoma. Very good, Bhavana. So, this is invasive lobular carcinoma. Now, let us see what is this India file or single file pattern. So, you can see these are the tumor cells and they are arranged just like soldiers or some people walking one behind another. So, similarly, this is the arrangement of the tumor cells, something like this, right. So, this is known as single file or Indian file pattern, right. So, very easy to understand, and Kumar Yo-Yo, very good bache. So, the moment you have this particular keyword, think of invasive lobular carcinoma, right. So, this is invasive lobular carcinoma and this is one of the favorite questions, like breast cancer. Definitely you will have a question either in pathology, either in surgery or integrated. Anyway, then this is more of medicine actually. So, a patient with cirrhosis develops abdominal distension and then the ascitic fluid analysis shows a SAG ratio of more than 1.1 gram per deciliter. What is the underlying mechanism? So, here patient is a known case of cirrhosis and then he develops abdominal distension. Obviously, this is ascites. Okay. So, now when this ascites is done, is evaluated, the SAG is more than 1.1. So, now here what is this SAG? So, SAG is, S is serum, then ascitic fluid, and what we are checking here, albumin, right. So, this is SAG. So, we have to check the albumin in serum and we have to check the albumin in the ascitic fluid and we have to take the difference between the two. So, how we will calculate that? Serum albumin minus ascitic fluid albumin, right. And if this value is more than 1.1, it means the ascitic fluid is actually a transudate, right. So, if this value is more than 1.1, it means the ascitic fluid is a transudate, and if you have studied about exudate or transudate, we know that the transudate happens when there is increased hydrostatic pressure, right. So, when there is increase in hydrostatic pressure, that will lead to transudate. And just to mention just one word for exudate, when there is any inflammatory condition, right, which increases permeability or leakage, clear. So, here even if you do not go with the options, simple thing is portal hypertension, right. So, there will be portal hypertension, in cirrhosis there is portal hypertension, and this will increase the hydrostatic pressure, that will lead to transudate. So, therefore, the SAG ratio will be more than 1.1. Clear? So the sag will be more than 1.1. So that's indicative of transudate, which is happening because of portal hypertension leading to increased hydrostatic pressure. Yes, Bhuvana, in inflammation, cancer, we will see exudative. Clear? So that's how you should remember. So the moment the value is more than 1.1, think of portal hypertension. It means the hydrostatic pressure is more. So that's a transudate. Next question, a renal transplant recipient develops graft dysfunction just 1 week after transplantation, and then biopsy demonstrate dense interstitial lymphocytic infiltrate with tubulitis. What type of rejection is most likely? Very good, very good. So here just look at the graft dysfunction. It is happening around 1 week after the transplantation surgery, right? So this is obviously one point which is helping us here, and then second, there is interstitial lymphocytic infiltrate with tubulitis. Okay, so with tubulitis, these 2 points are sufficient to call it acute T cell mediated rejection, right? So I think yes, hyperacute within minutes to hours, very good. So the moment you find somewhere around 1 week, then think of acute T cell mediated rejection. Okay, so this is how you should remember the timelines, because this is one concept which has been asked many number of times. So please be perfect with this concept. The next question, a child develops facial swelling after streptococcal pharyngitis. Then there is the immunofluorescence is showing granular IgG and complement 3 deposits. Now what you will see on electron microscopy? Very good, Bhuvana. So this is a classical case, like there is a history of streptococcal pharyngitis, right? This is one thing. After this, there is some kidney involvement, and the child is now having on immunofluorescence what we can see, granular IgG and complement 3 deposition. Now here the nomenclature is very easy. So this is post streptococcal, right? So you can write post streptococcal, and yes, this is glomerulonephritis, right? So this is a classical case of PGN and PSGN, where we are seeing where there is a past history of streptococcal pharyngitis. Now what we will see on electron microscopy? So yes, we will see subepithelial humps, right? So please remember this, subepithelial humps on PSGN. Okay, so Deepak, yes, Bhuvana, very good, bache. So this is PSGN showing subepithelial humps. And now here, because many times you may have different words like subepithelial humps or subendothelial deposits. So for that you need to know the basic electron microscopic feature. So suppose this is the basement membrane, right? So this is, say, glomerular basement membrane, what you call GBM. Okay. On the top of this you have food processes, epithelium, right. So, this is epithelial, and on the inside you will have the capillary endothelium. Okay. So, this is the capillary endothelium, right. So, now if there is deposition somewhere here, it is subendothelial. If the deposition is something like this is subepithelial, and sometimes under the podocytes we can see the subepithelial humps. So, suppose if I draw the podocyte something like this. So, if there is any deposition here, this is subepithelial hump. Okay. So, that is very characteristic of PSGN. So, this is say podocyte. These are actually food processes. Clear? So, this is what you need to remember. So, just look at the classical term subendothelial or subepithelial or subepithelial humps. Clear? So, here this is subepithelial hump, again the immune complexes are deposited here. So, that gives you a classical picture for PSGN, right. So, this is how you can see the subepithelial humps of PSGN. Chalo, moving forward. Now, this is a question, and I think here answer can be taken by the principle of exclusion, which is at times needed in the examination hall. So, patient with severe burns develops alveolar damage. Now, what microscopic feature is most characteristic? What you will see? So, case of severe burns, now he is having alveolar damage. Now, what do you think? What can be seen? So, here very good Bhuvana, ARDS, yes, perfect. So, here we will see ARDS, and in ARDS we see hyaline membranes. Clear? Because asbestos bodies, caseating granuloma, honeycombing has nothing to do with burns. Clear? So, this is how you can go with exclusion also. So, if you know severe burns, ARDS, hyaline membrane, nothing better than that, but this one you can solve with exclusion also. Yes, acute respiratory distress syndrome. So, hyaline membranes. Now, moving forward to one more very important topic and has been included many number of times. A patient with ulcerative colitis undergoes colectomy, right? And then what is seen on histology, that there is continuous inflammation which is limited only to mucosa. Now, what complication can be seen here? So, already this is a known case of ulcerative colitis, and histology, what we are seeing on histology, these are continuous lesions which are limited only to mucosa. Yes, very good. So, this has all chances of developing colorectal adenocarcinoma, right. So, this is what is complication of ulcerative colitis. So, colorectal adenocarcinoma. So, moving forward to next question, 70 years old smoker. So, elderly smoker has nephrotic syndrome. Then renal biopsy shows diffuse capillary wall thickening with subepithelial immune deposits. Which malignancy is classically associated? Now, here it's a elderly smoker developing nephrotic syndrome. Clear? And what we see here on biopsy, there is diffuse capillary wall thickening with subepithelial immune deposits. Very good, very good. Yes, this is a classical picture of membranous glomerulonephritis. Okay, so this is membranous glomerulonephritis, and yes, at times it can be a complication, or you can say a paraneoplastic syndrome, which can be seen in lung carcinoma, right. So, this is a paraneoplastic syndrome associated with lung carcinoma, and since the patient is an elderly smoker, so he has all possibility of developing lung cancer and secondarily involving the kidney, causing membranous glomerulonephritis, right. So, this is MGN, and the classical keyword is subepithelial immune deposits. Clear? So, this is subepithelial immune deposits. Very good, Bhuvana. So, this is MGN, paraneoplastic syndrome secondary to lung carcinoma. Then moving forward, a patient has a thyroid nodule. FNAC shows nuclei with clearing, grooves and intranuclear inclusions. Now, firstly we have to understand which condition is being discussed here. So, here known case of thyroid nodule, right. Now, what is happening here on FNAC, what we can see? Nuclei with clearing. Now, this is very important. Nuclei with clearing. Very good, very good. I think all of you can get from here. And one more important word is grooves, and the third one is intranuclear inclusions. So, out of the three, the classical word is nuclei with clearing, and yes, this is also known as orphan aniide nuclei. The nuclei, they do not have chromatin. So, nuclei without chromatin, or what you call optically clear nuclei. Clear? So, you will see a white nucleus. So, that is orphan aniide nuclei, that is classical for papillary thyroid carcinoma. Yes, this is papillary thyroid carcinoma, and this is related to RET PTC rearrangement. Okay, very good. So, this is how you can see this is the classical orphan aniide nuclei, right. You can see a optically clear, almost white nuclei without any chromatin inside, and sometimes you can see the grooves as well. So, these are the grooves here, you can see the grooves. Okay. So, these are the grooves, folds of the membrane, right. APCS, familial adenomatous polyposis, very good. So, this is how you need to diagnose the condition first, and then you have to associate it with the pathology or the question asked. Then next question, a 50-year-old male has generalized lymphadenopathy. So, there is generalized enlargement of the lymph nodes, and the lymph node biopsy shows Reed-Sternberg cells, RS cells, which are expressing or which are positive for CD15 and CD30. So, generalized lymphadenopathy, and then RS cells positive for CD15, CD30. Yes, this is classical Hodgkin's lymphoma. Okay, so this is classical Hodgkin's lymphoma. Very good. Yes, wonderful, wonderful. And here, if you feel the lymph nodes, they are rubbery, then Palestine fever, and many things. But for the time being, just remember CD15, CD30 positive, Reed-Sternberg cells, go for classical Hodgkin's lymphoma. Chalo, next question, a very basic question, and I think everyone can answer. Yes, very good, Kakul, you are absolutely right. So, a diabetic patient develops black necrotic tissue over the nasal cavity, which is extending onto the orbit. And then histopathology reveals broad aseptate hyphae with right angle branching. Saloni, very good, bache. Deepak, very good. So, now in this question, there are actually two parts. So, even if you are good with one part, you can reach up to the answer. So, the patient is a known case of diabetes mellitus, now having a black necrotic tissue involving the nasal cavity and then extending on to the orbit. So, this is classical mucormycosis, right. So, this is mucormycosis. Now, what else is given? Histopathology. That's very important, because at times this is straightforwardly asked, right. Very good, Bhuvana. Vikas, very good, bache. Kakul, very good. So, histopathology is showing you broad, right, aseptate and right angle branching. Clear? So, please remember this: broad, aseptate and right angle branching, go for mucor. Clear? Very good. So, everyone is right. This is one very favorite question for exam setters. Now, next question: a patient with severe hypertension undergoes renal biopsy, and what we are finding in renal biopsy is that there is concentric laminated thickening of the arteriolar wall. Now, what you will call this? So, the patient is a known case of severe hypertension, and renal biopsy shows you concentric laminated thickening of the arterial wall. Right. So, this concentric gives you, I think it will give you a classical idea that this is onion skin hyperplasia. Very good, Bhuvana. This is hyperplastic arteriosclerosis, right. So, this is hyperplastic arteriosclerosis, right. So, this is classical for severe hypertension, and hyaline, it is seen in benign hypertension. Yes, you are absolutely right. So, please remember this for benign hypertension, and this you can remember for malignant hypertension. And there is one more word which you can remember for malignant hypertension, that is fibrinoid necrosis. Very good. So this is fibrinoid necrosis. So there are two terms which you can remember for malignant hypertension. One is hyperplastic arteriosclerosis or onion skin hyperplasia, because there is concentric laminated thickening, and fibrinoid necrosis. And intimal tear, yes, that's very good for aortic dissection. It has nothing to do with kidney. Very good. Medial calcification is seen in Monckeberg sclerosis. Okay. So anyway, that's how you should solve this question. So this is onion skin hyperplasia. Next question, chronic smoker. So an 61 years old chronic smoker having persistent cough and is having elevated calcium levels, that is, yes, very good, Monckeberg sclerosis. So persistent cough and hypercalcemia. Then chest X-ray or chest imaging is revealing a hilar mass, and histopathology shows that it is a squamous cell carcinoma of the lung. Now, what is the reason for this hypercalcemia here? So yes, Bhuvana, this is squamous cell. Saloni Priya, bache, absolutely right. Deepak, Vikas, yes, everyone is right. So this is parathormone related peptide. So yes, this is a classical case of paraneoplastic syndrome. So squamous cell carcinoma, and here there is a paraneoplastic syndrome. Right. So I think most of you must be knowing what is paraneoplastic syndrome means. Like, there are some chemicals which are released by the tumor cells which act like the normally produced hormone. So what happens? There is overactivity of that particular hormone. In this case, this particular substance is acting like parathormone, and therefore the function of parathormone is to increase calcium. So that's now normal parathormone, and this substance released by the cancer cells, this is leading to overactivity of parathormone, and because of that there is raised calcium levels, that is hypercalcemia. Very good, Bhuvana. Right. So this is just something related to paraneoplastic syndrome. So you should know that. Yes, different varieties, they have different syndromes of lung cancer. Now, a 30-year-old woman develops hematuria, that is blood in the urine, 2 days after an upper respiratory tract infection. So URTI, and just 2 days later there is hematuria, that is blood in the urine. Now what else we can see? There is C3 levels are normal, right? So C3 levels normal, and there is mesangial IgA deposition. So I think that itself is very suggestive of the answer here. Yes, everyone is right. Bhuvana, Saloni, Deepak, everyone is right. So this is a classical case of IgA nephropathy, which is also known as Berger's disease, right? So C3 levels normal, then there is mesangial IgA deposition. So this is known as IgA nephropathy or Berger's disease. Yes, very good, Kakul. So very good, Bhuvna. And see, this time period is very important, 2 days later. So this is at time, we also call it synpharyngitic, right? So it is occurring almost by along with the URTI, right? So it is known as synpharyngitic. Yes, in PSGN, very good Bhuvana. This is synpharyngitic. Yes. So in PSGN the time is little more, maybe 1 to 2 week, right. So this is, you can see hematuria and this classical IgA deposition, and this is IgA nephropathy. Chalo, next question, in fact the last one for today's session. A woman has a thyroid nodule, then FNAC reveals papillary structures and orphan NEI nuclei. There are nuclear grooves and Samoma bodies. Now I think the moment you have these much of keywords, yes Bhuvana, you are absolutely right. So here a known case of thyroid nodule, yes, so it's a lady with thyroid nodule, and FNAC is showing us classical features. Yes, yes. So there are orphan NEI nuclei, then nuclear grooves, which are actually the folded nuclear membrane, and Samoma bodies. Yes, so the moment you have these much of keywords, the answer will come out to be papillary carcinoma of thyroid, and yes, it has a lymphatic spread. It usually spreads to the cervical group of lymph nodes. Very good Deepak, very good Saloni Priya, Bhuvana, yes, everyone, you are absolutely right. So this is lymphatic spread related to papillary carcinoma of thyroid. So this brings us to the end of today's session, and I'm very sure you must have enjoyed the session. Very shortly I'll come up with one more subject. Till then, keep on studying. God bless. Good night.